Morning, friends. I'm Dr. Professor Rahul Kawatra, Professor and Head ENT, and welcome back after a long break. I hope you had a good summer vacation. And in today's video, I am going to be actually telling you about the examination of the ear. And before we proceed to the video, there are a few things that I would like to tell you which you have to focus on. First is that the examination of the ear, when you get a long case or whether it is a short case, it is important that when you are asked to demonstrate the process of examination to the examiner, you have to see the correct position of the patient, the correct position of the examiner who is doing the examination, and the correct position of the bullseye lamp and your head mirror. So these things you must observe how I am doing it in the video, and at the same time you have to present your case in a sequential synchronized manner, which is important. What I mean to say is, like, as I have told in the video, that you have to start with the preauricular area, the pinna, the postoral area, the examination without the speculum, the examination with the speculum. I have specifically not mentioned about otoscopic examination because in undergraduate curriculum we are not supposed to have the otoscope, but the equivalent of otoscopic examination is the examination of the ear with the speculum. So you observe me carefully what all steps I am doing and how I am doing it, and what things you have to keep in mind is the steps. And if you do it in a sequential manner, you will not forget it. And I have also not talked in detail about the evaluation with the tuning fork test, or the facial nerve examination, or the examination related if we are suspecting complications. That I have not mentioned in this video because I'll be taking it separately and it requires a separate video for it. So thanks a lot, and watch it, and you will get useful informations in between and also in the end of the video. So please watch it till the end. Thank you. I'm going to talk about the examination technique for a patient who's got a problem with ear. Okay. This patient, this old man, I must give you a brief history, is complaining of discharge from the left ear since 1 month, with diminution of hearing since 1 month. Okay, and I am going to tell you the examination techniques. So first, what we start with is that the basic idea: the bullseye lamp is to be put on, and it has to be over the left shoulder of the patient. You have to keep your legs folded. Patients also has to be folded legs, and the position is made in such that the bull's eye lamp and your head mirror, this is the Mackenzie's head mirror, which has got a concave mirror. It's 9 centimeter in diameter and the aperture is 2 centimeters, and the focal length of this mirror is 25 centimeters. Okay, so at 25 centimeters you will get a good focus, and the part that needs to be evaluated is focused. In this case, we are examining the left ear of the patient. Patient is seated straight in front of you and with the head tilted. You should not move the body. Okay, so now on inspection, the areas that please come from the back and have a look. The areas that we need to inspect, that is the first thing, is the pinna. For pinna, you have to see the size of the pinna, the shape of the pinna, and the position of the pinna. These are the three important points that you have to comment. And if they are normal, then you say they are normal. So size wise, you can have microtia, a smaller pinna, or macrotia. Okay, the shape, you can have a bat ear or a Wildermuth's ear where the anti-helix becomes more prominent, right? And a bat ear where the helix is prominent and it is tilted in the front like this. Okay, and in conditions where you've got the position can be low set ears. In this case, it is a normal set ear because the upper limit is at the level of the eyebrow. If this level, the eyebrow level, if the pinna is set lower down, it is called as a low set pinna. Conditions like Treacher-Collins syndrome or other syndromic conditions, the patient's pinna is set low, that is that condition. So I'm just telling you a few conditions. After inspecting the pinna, you inspect the area of the preauricular area. Preauricular, commonest anomaly that you see is a preauricular sinus, which is invariably seen at this point in the area of the incisura. It is because of the incomplete closure of the tubercles, hillux of his. So there is a redundant space there or a sinus there, and which, if it gets infected, will start discharging. So you look for any pits, sinus, scar mark, endoral incisions, you can find scar mark, surgical scar mark, or any swelling in the preauricular region. That can be a preauricular lymph node which has separated, or preauricular lymphadenitis can be there. Okay, so these are the common things, or any cyst or any accessory ossicles or accessory tragus in the preauricular area. Then you inspect the post-oral region. The focus is in such a way that you focus the mastoid prominence, the mastoid tip area, and the post-oral crease area for any sinus, scar mark, swelling, or any cyst, right? So these are the common things that you look in the post-oral region. So this was the inspection, what you call as the physical examination of the ear, starting with inspection. Then you proceed with the palpation. So you again palpate the pinna for any tenderness. So if there is tenderness of the pinna, that indicates perichondritis. Then you have to palpate the tragus. The tragus, if there is tenderness of the tragus, it indicates tragus sign positive, which indicates otitis externa of the anterior canal wall. Okay, and then you have to do a circumduction test. Again, if the patient, it is positive, when the patient winces in pain, it means that the circumduction test is positive. All right. So that indicates the otitis, diffuse otitis externa of the external auditory canal, right? Then that is about the tenderness. Then you look for any change of color and you palpate for any crepitus or any swelling, that if that is there, all right, of the preauricular area and the post-oral area. Post-oral area, you specifically look for tenderness. Okay, so tenderness is very important in the post-oral area, and you look for the post-oral crease. And common area for palpation is the mastoid prominence, the mastoid tip for tenderness, and the cymba concha. This is the area of the cymba concha which corresponds to the suprameatal triangle, okay, and which corresponds to the mastoid antrum area. So this is indicative. If there is tenderness in this area, that means the patient has got mastoiditis. The other area is the mastoid prominence and the mastoid tip. You can do it with a 3-finger test with this side, and your thumb on the index, on the mastoid tip. But you don't press all the three at the same time. That has to be kept in mind. This is a 3-finger test to test the tenderness. Okay. Then you focus your attention on the post-oral crease. We are going in a very sequential manner. Okay, so from outside to in we are going. So post-oral crease is present in this case. It can be obliterated in cases of otitis externa. Okay, and in cases of mastoid abscess or mastoiditis, the pinna is pushed downwards and outwards, but the post-oral crease is present. So you have to differentiate whether the patient has got otitis externa or whether the patient has got mastocytitis. You have to, because there will be tenderness in both the cases. Okay, so once you have inspected the post-oral area for again palpate or any change in temperature, if there is any signs of acute mastocytitis or otitis externa, you will find the temperature raised of this, local temperature raised of this area and change in color. Okay, so pinna, preauricular, post-oral area, tragus sign and post-oral crease. So these are, and the mastoid tip. These are the initial findings which you do on inspection and palpation. Next, we focus on the external auditory meatus. So you inspect and see the approximate size, whether it is adequate or not, and then you withdraw the pinna, that is without speculum examination. So this is how you do it. You withdraw the tragus and you withdraw the pinna, and how do you withdraw the pinna? It has to be pulled upwards, backwards and outwards, right? Upwards, backwards and laterally or outwards. It means the same. So you straighten the cartilaginous part of the external auditory canal and you inspect the external auditory canal without the speculum, and you see the outer cartilaginous part of the external auditory canal for any debris, wax, foreign body or any sinus or fistula there, or any scar mark there, and for any keratosis obturans can be there, or any osteoma formation can be there. So any obliteration and collection, pus, discharge, anything there in the external auditory canal, that has to be mentioned present or absent when you are presenting your case. Okay, once you have done a without speculum examination, then we go ahead with the appropriate sized speculum for evaluating the inner aspect, the osseous part of the external auditory canal, right? So this will straighten the cartilaginous part. The use of the speculum is that it focuses the light, it concentrates the light on the inner side, and it straightens the cartilaginous part of the external auditory canal as well as the hair bearing area. Though this patient does not have much hair, but some people have a hairy external auditory canal, so it takes care of that also. It pushes the hair on the sides of the walls so that you get a clear image inside. So that is how you hold the pinna as well as the speculum with one hand. So that is how you do it, so that you get a full focus on this, or you can hold it in this manner also. If you feel that the light is getting obstructed, you can hold it like this. So with one hand I am pushing it outwards and backwards, and with the other hand I am holding it between the thumb and index finger. So I get a pure clean image inside, and I can visualize the tympanic membrane. Okay, so in per speculum examination, you are supposed to tell the remaining part, the bony part of the external auditory canal and the tympanic membrane. So again, you talk of the discharge, the debris collections, any foreign body there in the external auditory canal, or you might, and then you talk about the tympanic membrane. What points are you supposed to tell on the tympanic membrane findings? Is the position of the tympanic membrane is gently bulged outside, okay, whether it is retracted, bulged or normal position. Or next is the color of the tympanic membrane. It is pearly gray in color, which is normal. It can be reddened in cases of acute otitis media. It can give a waxed appearance in cases of secretory otitis media, okay, or it can give a bluish hue in cases of hemotympanum or glomus duglaire, right? So these are the common colorations of the tympanic membrane. Then you have to talk about the other parts of the tympanic membrane, that is the cone of light, whether it is intact or not. In fact, cone of light is the first sign that appears on the tympanic membrane. In an abnormal tympanic membrane, that is the first thing that gets distorted or absent. So that has to be very clear that the cone of light is present or it is absent. You have to mention that. And cone of light is commonly present in the antero-inferior quadrant. So once you've discussed about the cone of light, you have to talk about the handle of Malleus, the anterior malleolar fold and the posterior malleolar fold. So anterior malleolar fold is prominent or less prominent. The handle of Malleus is normally placed, or whether it is foreshortened. It gets foreshortened in retracted tympanic membrane. If there is a tympanic membrane retraction, the handle of Malleus becomes more prominent, it becomes foreshortened, and even the anterior and posterior malleolar folds will become more prominent. So that is what it is. So then you comment about the tympanic membrane part, that is the pars tensa, and the part that is above the malleolar folds is your pars flaccida, or it is also called as the Sharpnell's membrane. Okay, so when you focus, so you have to have a clear view of the tympanic membrane, both the pars tensa as well as the pars flaccida. Okay, so then next point that you commonly have to comment about is the perforation on the tympanic membrane. So the important points that you need to talk of in perforation is the site of the perforation. In site, you have to tell whether it is on pars tensa or whether it is on the pars flaccida. Okay, then the number of perforations, it can be single perforation or it can be multiple. There are certain conditions where we have multiple perforation, which is commonly trauma. You can have more than one perforation. Tuberculosis also you can have more than one perforation, and in malignancy also of the middle ear. So you can have multiple perforation in these. These are the common conditions where you have multiple perforation. Otherwise, usually in undergraduates we give cases of chronic suppurative otitis media. There will be a single perforation. Then after the number of perforation, then you have to tell the site of perforation, the size of the perforation. Site we have already discussed, number we have already discussed, the shape and the size. The shape can be rounded, oval or kidney shaped depending upon the quadrants involved, and based on the quadrants involved you tell the approximate size of the perforation. Okay, so if we were to talk of, just focus here on the paper, if we were to talk, let's say, of this left sided perforation, if there is there, so now if this is the imaginary line which passes vertically across the handle of Malleus and the umbo, and you bisect it at the umbo like this, so this divides it into 4 equal quadrants. This is the antero-inferior quadrant, this is the antero-superior, this is the posterior-superior, and this is the posterior-inferior. So if the perforation is like this big, so this means this pars tensa area is an approximate square of 8 by 8, and bifurcating it into 4 quadrants of 4 millimeter each, 4, 4, 4 and 4. Okay, because the average length diameter horizontally is of tympanic membrane is 8 millimeters and vertically it is 9 to 11 millimeters. So 2 millimeters of pars flaccida area we leave. So this becomes 8 and 8 equal quadrants. That's how you approximately measure. So when you look, you have to see where exactly it is. It is in the antero-superior quadrant, and it is lying well within the levels of the tip of the handle of Malleus, that is the umbo, and the malleolar fold. So this is within the size of 4 and 4. So this becomes approximately 3 millimeter by maybe 3 millimeter size perforation. That's how you give an approximate idea how big is the perforation. Otherwise, you are not measuring it with anything. Then if the perforation is involving more than one quadrant, it, then approximate size, if it is within this area, it is around 3 millimeters. If it is involving more than one quadrant, then it can be anything more than 4 millimeters, which can be 6 or 7 millimeters. So you really doesn't make much of a difference, but it is important the number of quadrants. Based on that, it can be a small perforation, it can be a moderate perforation if it is involving more than one quadrant. If it is involving 3 quadrants or 4 quadrants, then it can be a subtotal perforation. And if the perforation is involving the annulus also, then it becomes a total perforation, right? So it is important that if the perforation is on the pars tensa, then we call it as a central perforation. What is a central perforation? Central perforation is a perforation which is present on the pars tensa. Number 1 point. Number 2 point, it has got a rim of residual tympanic membrane all around it. So a central perforation will not involve the annulus. It will always have a residual tympanic membrane all around it. So that is what is a central perforation. It does not mean that the perforation is in the center. Let us be very clear about it. Okay. And if the perforation is involving the margin, supposing it is involving one end of the margin like this. So one end of the annulus is involved, then it becomes a marginal perforation. Okay. So that is what is. Or if the perforation is present in the pars flaccida, then it becomes an attic perforation. Okay. So then once you've described, then you have to tell about the margins of the perforation. Margins are irregular or regular. That you have to tell. Irregular margins are again commonly seen in trauma, tuberculosis and malignancy. Okay. And regular margins are commonly seen in chronic suppurative otitis media. Okay. So you have to tell the margins are regular. Then you have to comment whether the margins are dry or wet. So dry means the perforation is in active phase of CSOM. And if it is wet, it indicates that it is in the active phase of CSOM. Okay. Then you comment about the structures seen through the perforation. So if there are certain structures which are present behind the tympanic membrane, in the posterior-superior quadrant, you have got the incudostapedial joint and the stapes suprastructure. At the junction of the antero-superior and the antero-inferior quadrant, you have the Eustachian tube gutter. In the posterior-inferior quadrant, you will have the round window niche. So based on where the perforation is, if the perforation overgoes the area of the posterior-inferior, it is involving the antero-superior, antero-inferior margin also, as well as in a posterior-superior area. So if it is a large subtotal perforation, then you have to comment about the visualization of the incudostapedial joint and the stapes suprastructure and the round window niche or the Eustachian tube gutter, and of course the promontory. Promontory is the mucosa that overlies the middle ear. Okay, that is the middle ear mucosa. The promontory, about promontory, you have to again comment whether it is dry or wet. It is color is pink or pale in color. If there are any secretions there, then it is what kind of secretions are there, serous or purulent secretions present in the promontory, or if there is any polypoidal changes on the promontory. The polypoidal mucosa makes the promontory bulgy. Okay, so there is a gentle bulge. So you have to tell that the promontory mucosa appears to be edematous, and there is polypoidal changes on the promontory mucosa, right? So you can have a small polyp coming out through the perforation through the middle ear because of the promontory mucosa being more edematous. So if there is a polyp coming out, then you have to probe the polyp to understand from where the polyp is coming out, but you never pull the polyp. Okay, so ear probing also is required in certain cases. So this is basically about the perforation. And you are talking about the size of the perforation, the shape of the perforation, the site of the perforation, the margins of the perforation, whether they are dry or wet, the number of perforations, and the middle ear structures seen through the perforation. So these are the 7 points that you talk of about the perforation. So this completes your examination with the speculum of the ear. So once that is done, so this completes your physical examination of the ear. Then you proceed to the functional examination. In functional examination of the ear, the common test that you are supposed to do is a fistula test. That is when you are suspecting a erosion of the semicircular canal. Then there is a communication with the inner ear. In that condition, how do you do a fistula test? You just give intermittent pressure over the tragus. You don't have to give one pressure, you have to do intermittent pressure. And you have to look into the eyes of the patient and ask the patient if the patient is feeling vertiginous. Have sensation of vertigo and the presence of nystagmus indicates the erosion of the semicircular canals. And the most common semicircular canal that is eroded is lateral semicircular canal. So if the fistula test is positive, means that invariably there is an erosion of the semicircular canal. There are conditions when there is no fistula, yet it can be positive. That is called as a false fistula test. They are seen in hypermobile stapes or post-stapes surgery. Okay, in syphilis, these are, which is called as the Hannenberg sign. So these are the common conditions where there is a false positive fistula, and there is a false negative fistula when the fistula is obliterated by a cholesteatoma sac. So that means there is erosion, but it is blocked by the debris of the cholesteatoma. Okay. So this is the vestibular examination test called as the fistula test. Then you are supposed to focus your attention on the facial nerve. You will ask, Babaji, aankh band kariye. So you check for the kas ke band kariye. So and you see the और भौहें ऊपर उठाइए, आँख खोल के भौहें ऊपर उठाइए. This is the forehead wrinkling, the eye closure. दांत दिखाइएगा ऐसे. हाँ. So these are the common tests. ठीक है. These are the common tests. और ये जब ऐसे ऊपर करिए, थोड़ी ऊपर करिए. Okay. So this is the platysma that you are checking, the mentalis you are checking. Then this is the depressor anguli oris that you are checking, and the orbicularis oris. ऐसे मुंह फुलाइए. This is the orbiculi oris that you are checking, and आँख बंद करिए. ठीक है ना. The orbicularis oculi you are checking, and the frontalis muscle when you are asking भौहें ऊपर उठाइए. So this is the occipitofrontalis muscle that you are checking. So that gives you a impression. In unilateral lower motor neuron, you will have single side facial palsy. You will be having the facial expressions will not be there. The angulation will be there on the side but not on the affected side. The nasolabial fold will be absent and the patient will not be able to blow. Okay, and there will be drooling of saliva on the affected side. So this will indicate a involvement of the facial nerve. Commonly in unsafe CSOM, at the second genu level, there is an erosion of the facial canal or edema of the facial canal will lead to a facial paralysis. So this is unsafe ear condition where you have an involvement of the facial nerve. Other functional test that you do is the function of the Eustachian tube. Now, Eustachian tube function test, commonly you do a Toynbee's maneuver, जिसमें आप पेशेंट को नाक मुंह बंद करके ऐसे निगलिए, नाक मुंह बंद करके अंदर निगलिए और नाक मुंह फुला के कान से हवा निकालने की कोशिश करिए। देखिए आपको ऐसा लगता है कि हवा निकल रही है, यहाँ से खुर खुर होता है, so that shows that the Eustachian tube is patent. If the patient says कुछ नहीं पता लगता, means the Eustachian tube may be blocked. In case of a perforation, you can even see, if it is a wet perforation, you can see the bubbles coming out. So that shows the intact Eustachian tube function. Other way is using a pneumatic speculum. So you give pressure and you ask the patient if he feels air in the throat. So all these things indicate towards a normal Eustachian tube function, right? So functional examination will examine the vestibule, the facial nerve, the Eustachian tube functions, and if you are suspecting complications, you inspect the other cranial nerves also, 3rd, 4th, 6th, 9th, 10th, 11th and all, if you are expecting any tumorous growth in it, or if you are suspecting any intracranial complications, then you will do the test for the raised ICT and the signs of meningeal irritation, right? The Brudzinski signs, the Kernick sign, and the neck flexion, neck rigidity, all those things, and the cerebellar function test also can be done in the latter part, right? That is the tandem walking, dysdiadokinesia may be present, okay? So these are the tests for the cerebellar function test. So this, if we were to briefly summarize the examination of the ear, it is the physical examination, which involves the inspection and the palpation of the preauricular, the pinna and the postoral region. Then the palpation, which mainly involves the tragus sign, which is for the otitis externa. Then the inspection of the external auditory meatus. Then without speculum examination, where you are just gently lifting the pinna upwards, outwards and laterally, upwards, backwards and laterally. Okay, in children you pull it upwards, outwards and downwards, because there is in the bony canal is not fully formed. So that's you pull it downwards in children. Okay. So this is without speculum examination. Then you use the ear speculum. There are various ear speculums like Tomarkin's ear speculum, which is slotted. You've got a Hartmann's ear speculum. You've got Pulitzer ear speculum. There are various ear speculums, which is mainly, but the function of the ear speculum is to straighten the canal, hold back the hairs, and so that you can get a better view inside. Without speculum examination, with speculum examination. That completes it. One thing that we've left out in the functional examination is the tuning fork test, which I'll be telling you in the next presentation. But the common tuning fork test that you are doing is the Rene's test, the Weber's test, and the Schwabach's test, or the and ABC. So these are the 4 tests that you do to check the auditory pathway of the ear, right? So you have to tell the vestibular pathway, you do a vestibular function test or the fistula test, you do a tuning fork test, you tell about the hearing issues, you get an idea what kind of hearing loss it is, whether it is a conductive hearing loss or whether it is a sensory neural hearing loss or could be a mixed hearing loss. So this will get to know from your tuning fork test, and the degree of extent of hearing loss can be known by doing tuning fork test with the 3 tuning forks, that is your 256, 512 and 1024 Hz, right? So, and followed by facial nerve examination. The examination, if you are suspecting complications, then intracranial complications you are expecting, then you look for the signs of meningeal irritation or you do the cerebellar tests. Okay, so that completes your complete examination of the ear, because at the end of the day, what is important is that you are taking the history and you are doing the examination, and you have to corroborate your findings in the history and the examination to support your diagnosis. So the examiner will ask you what is your diagnosis. So in this case, this is a case of left-sided chronic suppurative otitis media, tubotympanic type, active stage with conductive hearing loss. Okay, so that is how you tell your diagnosis. So you have to give points in support of your diagnosis in your examination and in your history. Examination findings, mainly your central perforation, and you describe that perforation. The tuning fork test will tell you about the conductive hearing loss. Okay, and in history you talk about the nature of the discharge, the type of hearing loss that is there. Okay, and if there is any vertigo or tinnitus present or not. So this will complete your complete examination of the ear. Okay, and in detail I'll tell you about the facial nerve examination and other cranial nerve examination, and also about the tuning fork test in a different class. Okay, I hope I have briefly told you how to do it, and I should be clear with you. And you are free to post your questions, and I'll be happy to answer them. Thank you very much.